afternoon. Welcome to the Center for Change webinar series. My name is Tamara Bingham. I'm the Director of Business Development here at Center for Change. I'm here with Rebekah Cook, who is our Director of Dietary Services and an amazing human. And I'm excited for you all to be able to hear from Rebekah today. I'll talk a little bit more about her in just a minute, and then I'll turn it over to Rebekah. But we want to do a couple of quick housekeeping things before we get started. So you'll see some notes on your screen. The first is that a copy of the PowerPoint is in the handouts section of the toolbar. You're welcome to access that if you'd like. You can download it from there if you'd like. It's also on our website under our webinars tab. Excuse me. First of all, I guess I should have said I'm recovering from bronchitis. So I apologize if there's a cough here or there, and I'll do my best to rein it in. So you can find the PowerPoint on our website as well. In that same section, handouts section, you'll also find a copy of the post test. You can look at that and utilize that for references, but you'll take the test online, and I'll talk about that in just a minute. You're welcome to submit questions in the questions section of the toolbar. We'll try to get to a few of those at the end. We just have too many folks on to be able to do questions in the moment, so we'll save those till the end. I'll keep an eye on those questions throughout Rebekah's presentation, and then we'll come and address some of those at the end as we can. When the webinar ends, excuse me, please fill out the evaluation that pops up on your screen. This is a continuing education requirement for Center for Change. It's completely anonymous, so please feel free to be candid in your feedback. We tabulate those results and then send those to the CE entities to complete the CE process. And then about an hour after the webinar ends, you'll receive a separate email from GoToWebinar. It will look similar to the email you received when you registered, but it will have the link in that email to take the online test. You must take the test online in order to receive continuing education credit. Once you take the test and pass it online, the CE certificate will automatically be downloaded to your computer. So if you don't see it on your screen, check your downloads folder. Okay, I know Rebekah has a ton to present today, so I don't want to take any more time than that. I'll pop on at the end to give you a reminder about how to take the test and to also answer some questions. We're so happy to have Rebekah with us. Rebekah actually was at Center for Change. We were talking before we came on live 25 years ago, which I said to Rebekah is shocking because she still looks 25. So she started at Center for Change 25 years ago and helped us implement intuitive eating into our program, which is a key component of what we do at Center for Change. So, and then we're blessed and lucky and grateful that we get to have her back after a period of time where she was out and about doing other things, and now back at Center for Change directing our dietary services there. So I'm going to turn it over to you, Rebekah. I'm going to hand you the screen. So let's do that real quick. And it should be popping up for you. There it is. Okay, I'm going to turn off my mic and my camera, but I'm right here if you need me. So holler if something goes south. We'll figure it out together. Otherwise, I'll turn it over to you, and then I'll pop back on at the end of the presentation. Take it away, Rebekah.
Thanks so much, Tamara. So as Tamara said, my name is Rebekah Cook. I'm the Clinical Nutrition Director at the Center for Change, and I did work at the center in '98 to about 2002, and then worked in Los Angeles in several different treatment centers, but then also in private practice for a while, and then have come back here, which is super exciting because the people at Center for Change and the work they do is super important, and I appreciate that opportunity, having the opportunity again. All right, so what we're going to discuss. First, we're going to discuss the recovery model. We're going to talk about collaborative care. We're going to talk about biases and beliefs that could make a difference in how we work with patients. We'll talk about weight goals, and then also we'll talk about kind of some fun interventions. All right, so I started or even had an interest working in eating disorders because at one point in my life, when I was 14, I had anorexia. Now, I have a sister on the left who also had bulimia about 8 years after me when I was working at the center for several years. And then my middle sister, she's older than me, actually has ARFID, but more like the texture type issues. And I bring this up really because it is a family type of it can be familial in a way that certain brains kind of just would be more apt to pick up eating disorder behaviors in certain circumstances. And then I also want you to just, I'm going to bring this up a little bit later when we talk about biases. But I thought I'd give you a little bit of background there. And the recovery model. So first, with recovery model. So it's Substance Abuse and Mental Health Services Administration defines recovery as a process of change through which individuals improve their health and wellness. They live self-directed lives and strive to reach their full potential. Anyone can recover and or manage their condition successfully. So the important term here is more manage their conditions. So for some people, they might get the idea that there's, you know, more that dichotomous way of thinking about recovery. There's this all or nothing, and they may have more of the idea for their life where recovery could be managing their conditions, and we want to be kind of open to that diversity as far as with recovery as well, that we are accepting of what they want. So as professionals, maybe we need to look at recovery using a different lens, and as opposed to our way of thinking about it. Now, to move towards recovery, the individual must reach a turning point where they develop insight into the function and consequences of anorexia. So this was a study with anorexia, and commit and take responsibility for recovery. So as we all know, it's hard to make anybody get better. And once they choose that they want to change things, it makes our job a lot easier. Now, in the meantime, we want to be able to help patients have some semblance of life and create a therapeutic relationship where we believe in them and are supportive. And this has actually really come into play more now with the new APA guidelines that were just put out. And where part of the idea is to be able to work with patients and kind of keep their lifestyle. So it might be more outpatient. And we know that the process of recovery can take a long time. So we want to create that therapeutic relationship where we can follow them through the process and be respectful of their process. So we need to know what is the patient's view of recovery. What's their life path, their values, their timeline. Now, of course, with our adolescents, it could be more, it's a little bit different because we also have to kind of work with really the parents more than, not necessarily more than, but it's going to really matter what the parents want in those situations. And their route may be different. It may be different from what we've seen in the past. It may be different from what we expect. And maybe we need to look at them functioning in life versus full recovery. So with some patients, if I have an older patient who's had, say, bulimia for 50 years, and she's purging, 3 times a week, and she says, well, gosh, this is the best I've ever done in my life. I need to be able to celebrate that with her, as opposed to being like, well, let's not have you purge at all, because she was pretty proud of herself for just doing it 3 times a week. Now, what they can do now is okay, and they're not failing just because their recovery is not picture perfect. And it's important too, as a professional, to also realize that we're not failing because their recovery is not picture perfect. Because I do think sometimes we get very invested in their recovery and could feel like we're just not doing a good job if they're not progressing. So exploring recovery beyond perfection required participants to let go of a dominant vision of the perfect image of recovery, which is not easily done, particularly when so few visions of recovery are available to those seeking them. Now, we do have professionals who have recovered from an eating disorder that work in treatment. So those could be some images of recovery, but there may be an idea that, okay, if I don't have the recovery like the therapist I work with, then I'm not really, it's not okay. It's not good enough. And some parts of their just way of thinking about life in general might come from the point of, okay, I'm not good enough. So we don't want recovery to be that same way, that what they're doing is good. And having professionals and mentors with lived experience, it can be extremely helpful in giving patients hope. I have worked at one point in time, there used to be the idea of not hiring people who've had eating disorders. And that's changed a lot. I have worked in some places where almost all of the clinicians have had eating disorders, and it can be very helpful. So if we look at what recovery looks like for somebody who's recovered, you can see that it's a very complex issue, and that there might be a lot of different things that might have led them towards recovery. So we can see in our bottom left-hand corner of the screen, I really like this, that eating disorder is not a choice, but recovery is. It's a complex process, not one size fits all. I always say my recovery, especially because it was a point when, I was in a psych ward, so, and they didn't really have many treatment centers. I think there was maybe one in the country, but I would consider it more of a patchwork recovery, like really just picking up things from different people and wanting to have my relationship with my body and food be different. There's also the idea of no mud, no lotus, that it's all not, it's all not flowers, some of it's mud. There's everyday life, social justice issues. So there's a lot going on, a lot of things that make a difference for different people in recovery. So sometimes we want to pay attention to, is it our resistance or theirs? Here and there, you'll hear colleagues say, okay, the patient's resistant. Okay, that's possible. But sometimes what we believe is a patient's resistance is really our resistance to listening to what the client, and hearing what they say is valid. So it could be that that our values, expectations, and beliefs may be trumping what they say theirs are. We want them to be a certain way or recover a certain way. So that's kind of the idea with the recovery model. With collaborative care, this was a study where they put more of a collaborative care model into a treatment center. And what you can kind of think of collaborative care as being is working with the patient to create the life or recovery they want. And what they found is it increases outcomes in eating disorder symptoms, psychological functioning, increased well-being, and treatment satisfaction. Now, there's a common term that's like, okay, the patient's dictating treatment. I've heard that before. But there are some things that we have in treatment settings that are non-negotiables. And those are important because it helps separate somebody from their eating disorder, but it also helps maintain the milieu of the treatment setting. But what we can do with these non-negotiables is we can provide a rationale. So that's one of the things we do at the Center for Change, is providing a rationale of why we have non-negotiables. We want to have consistent implementation. We want to give advance notice so that they know, hey, this is a rule, this is a non-negotiable, and we need to provide choices. It would be like with a child, if you want them to brush their teeth, it might be, do you want this toothpaste or that toothpaste? That's a choice. And that's simplified, but providing some sort of choice can be very helpful. Now, another thing that's important here is recognizing our power, privilege, and if we come off in an authoritarian way. So anybody who's a clinician in a treatment center, we have a fair amount of power and privilege in that setting. And we actually do have a lot of power to affect their experience. They are coming in for help. So we have to be really aware with everybody of how we are, that we're not coming across as being authoritative, but we are working with the person, especially when we have anybody who's in more of a marginalized situation or marginalized in the culture. And that can be with weight. So they could be marginalized with being in a larger body. They could be marginalized with gender, age, being older, or ethnicity. So all of those things could be where we really need to kind of pay attention. And then with intersectionality is when you have two things. So maybe we have somebody who is, say they're transgender and they're in a larger body. Well, those are two things that they could have been marginalized for. And so we need to be really aware that their experience of life could be very different than somebody who, say, is just transgender. So that's what intersectionality means. Now with authoritarian, we are, as dietitians, we do tend to be taught more of presenting information in an authoritarian way. And that can be a problem. It can cause resistance. Nobody likes to be told what to do. Maybe there's some people that like that, but it can affect the relationship we have with our patients. Even if we're right, it doesn't matter because what it is really just causing that conflict. And if we're presenting things in more of an authoritarian way, we're not necessarily taking their experience into account or what they want. And sometimes we can expect too little or too much. So maybe we might expect them to be like intuitive eaters, and that's not what they're interested in. Or we could assume, well, they're not going to recover. So maybe we could expect too little. But that's also we'll talk about that with biases. Now, collaborative care in various treatment settings. What's really important here is with inpatient is speaking to patients, speaking to them and not at them. I have had patients before tell me that, you know, that their dietitians speak at them or to their eating disorder, and they don't feel like they're speaking to them as if they matter or them as a person. So we really need to kind of get beyond our biases that way, or maybe it's what they look like that could affect how we speak to them. And we want things to be less educational and more conversational. We want to really get to know patients, treat them as we'd like to be treated. We want to find out what recovery is to them. And we also, with weight goals, we want to obtain informed consent. And so this is quite an important concept for me because at times I'll get, and I supervise a fair number of dietitians, but at times I'll get a dietitian who wants to put a patient's weight to a certain place, but not talk to them about it. They just think they're right, so they want to do that. And I use the analogy of a doctor amputating somebody's leg. And so they amputate, say maybe the person comes in and the doctor says, I need to amputate your leg at the knee. And the patient's like, no, I'm afraid of that. Could we just do antibiotics for a while? And the doctor may say, well, sure, but we might have to amputate your leg a little higher if we do that. So those are choices, right? We're offering choices. Or it could be, well, could we amputate the ankle and see how you do? Now, this might seem like a strange analogy, but for some of our patients, restoring weight could be as scary to them as having their leg amputated. So it is important. It's an important topic for them. And you can think about this. If we're creating a relationship that's going to last until they're recovered, whatever that is to them. If you went into a doctor's office and they just knocked you out and amputated your leg, would you go back? No, you just would have lost trust in that person. So it is important to talk about things and to be open, and that's really how you might want to be treated as well if you were in that situation. So we want to offer options and let them choose. And remember, it's always the patient's choice. There are exceptions. So an exception would be if it is life-threatening, if it's a medical, something's going to happen right away. That is more of an exception. Now, we also want to encourage autonomy and initiative. So it could be where we would ask a patient, well, let's make some recovery choices if that's what you're interested in. Would you be willing to ask for more food to help with weight restoration? Because that takes a lot of courage, and that would help you do opposite of your eating disorder. So that's helping them not just be kind of stuck in treatment, but they're taking those steps. Now with PHP and IOP, it's really important to help patients find support. And sometimes they don't want to burden somebody else. And one of the things I like to say is, it's not that you're burdening somebody, it actually, you're giving them the opportunity to contribute. And that makes people feel good about themselves. So it's not like you're a burden, you're offering them the opportunity to feel good about themselves. So sometimes that makes a difference in how they think about it. And then also, yes, of course, encourage them to take initiative. Okay, so biases and beliefs. I want you to think about what you thought when I showed you this picture. And you have 3 people in the same family who had eating disorders. Is there an idea of what their parents do wrong? Or I wonder if they're okay, or, it could be a variety of things. And I bring this up because I recently, and I feel like I'm not biased at all. So I can tell you, my sister still doesn't eat meat. She has texture issues, and she's not interested in changing that. But my sister who had bulimia and me, we're both intuitive eaters. We have kids, we have lives. It was a long time ago. Both of my sisters are school counselors at high school, so they are, have really good lives. My parents were not dieters. They didn't talk about food. We never had any abuse in our life. We had just normal adolescent issues. So that's my background there. But what I've experienced recently, I had somebody who was in a meeting share with me that she had 2 daughters who had eating disorders, and I thought, I wonder why. There was a bit of judgment there of what was done wrong, or why did that happen, or so even with me having an experience of where I know my parents didn't do anything wrong, and we're okay now, we're totally fine with food and everything. But and 25 years later, there's still this little what is wrong if somebody has a family who has 2 kids who have eating disorders. So I want you to think of that. And then also, what you also want to pay attention to is how that biases limit their recovery, how your biases might limit your patient's recovery. Because biases are natural and normal. We all have them. So it's not something to be like, oh, I don't have any biases, because humans have biases. So what do you believe about a patient who has an eating disorder? What do you believe about maybe somebody who has atypical anorexia and is in a larger body? What do you believe about somebody who has repeated admissions? How do you speak about those patients? Are we offering them that opportunity to recover every time they're here, or are we sandbagging their recovery because we don't believe they can get better? So it's important to be aware of what you consider possible. Because how you speak to somebody could really change how well they do in treatment. If you don't believe they can get better, your way of speaking, way of acting with that person will limit them. You may not think you're bringing that across in a conversation, but it's pretty apparent. These patients are very perceptive. Now, they did a study on dietetic interns and weight and eating disorder biases. And the interns were sure they were not biased when it came to weight or eating disorders. And they found that they were biased against people in larger bodies and also biased against people who had eating disorders, and actually more biased against people who had eating disorders than somebody in a larger body. Patients don't want to be seen as the deviant other, and this did come from a patient in recovery of how she felt like she was perceived by staff. So we do want to just really be aware of making sure that the patients know that we care, that they are people, and that we believe in them. All right, so moving on to some usual weights and measures. Unfortunately, there's no consensus in defining weight restoration for adults or adolescents. So really no consensus in defining weight restoration for anyone. It is an art. It is not a science. It could be different for a person at a certain time in their life. So it's not always going to be this exact place. How do we set a goal body weight? So most of the time, we're using growth charts. If somebody's 20 or younger, we ask what their weight was before their eating disorder, but they could have been emotional eating. They could have had a lot of different issues. So we really just need to kind of ask about all those types of things. We do use BMI, but that's mostly because the insurance companies do care about that. There's a BMI that's recommended more from the APA that would be about 20. That doesn't mean that you get somebody to a BMI of 20 and everything's good. It's just that's kind of that low end. And some people may also be lower than 20 if they're like 13 or their families are a certain way. So we have to allow for diversity. Set point would be where somebody's body naturally goes when they are not doing anything to manipulate their weight. So they're not changing their food. They're not changing their activity. It's just where it kind of will go. Now, do know people's weight, it would change if somebody was more active. And I kind of think of this like, okay, so if somebody is more active, would their body always tell them, hey, eat more? It will at a certain point, but at times it will kind of shift. Maybe they're being more active, so their weight goes down. Maybe they're being less active, so their weight goes up. Would intuitive eating always keep it the same? No, because that activity does kind of shift things. And I think of that kind of like brushing our teeth. If we don't brush our teeth, would it change the way our teeth look? Sure, a little bit. And it is also difficult to predict in advance the weight that will support full recovery from anorexia. And when psychological recovery lags behind weight recovery, which it can do, it can be particularly difficult. So say if we get somebody to a certain weight and we think, hey, you should feel better, which a lot of times weight recovery doesn't make anybody feel better, only sometimes. That can be difficult. Now, a couple of things I wanted to point out from this study. This is a follow-up to the Ansel Keys study. So this is when we had people back in 1940s and they volunteered to have their weight reduced or to be starved so that we could learn how to refeed them. They were conscientious objectors. And two things that really kind of I thought was very interesting from this was, one, there were a couple people that actually their weight had to go higher than it was before. So say they were at a certain weight, they had to lose that weight for the study, they brought them back, but in order for them to not have maybe an altered relationship with food, their weight went higher. And then years later, it went down. So this is what happens sometimes, that weight will go over what it was before they had an eating disorder. And then and this is where intuitive eating can be really helpful, because yes, we cannot choose where our weight is in order to recover, and we cannot diet in order to recover. That just doesn't, none of that works. You can never diet again. Their weight will readjust over a period of time, but it would be slow enough that it's not an obvious thing. So that's one thing, is there is some overshoot that some people experience, and that is hard, for a hard experience for people, and people sometimes do have a hard time being patient. The other thing is that one person from this study, their weight went, they did the weight loss, and then it went back to that normal, or their normal place where they were before, but they felt bigger than they were before. They liked their body before the study, and after they felt too big. So that's something to be aware of, is that the perceptions can change even if they were okay with their body ahead of time. And so it's just, there is diversity in recovery as far as how somebody experiences things, and even what weight we need to get somebody to. Now, I looked up some novel weights and measures, and there's one that I think is quite interesting. So this is called the mass index. And what this does, so any type of measures we have would be averages. It's not going to be exact. So the body mass index assumes somebody's legs are a certain percentage of their body height. So this is the mass index, and it's 0.53 times your weight in kilograms divided by full height in meters times your sitting height in meters. What this does is, most of our weight is in our torso. So some people have longer torsos and shorter legs. And what this formula does is really just even that out. So it would actually drop their BMI if we take into account the length of their legs. Because we will have patients who have long torsos, shorter legs, or we'll have somebody who has a shorter torso and long legs. And that would mean that we might have to get them to a little bit higher BMI because they have such a short torso. So I just kind of find this one a bit fascinating, and just to keep it in mind because it's interesting. Now, body fat percent is important. So the relative body weight without accurate and reliable assessment of body fat is a weak criterion for healthy weight. So there was a study where they did more of the subcutaneous adipose tissue, and they tested this with ultrasound. So the patients with the BMI, they had 13 to 17 BMI, but they had subcutaneous adipose tissue that ranged from 1.3 to 58.2 millimeters. So that's an enormous difference. And they had very similar BMIs, but enormous body fat differences when they kind of put this, 17 BMI and put them next to each other. The body fat could be very different. So that's why we can't really use weight. We need to have our patients to be at a good amount of body fat. Now, 21.2 is the total body fat cutoff point to resume menses. According to this study, as I mentioned before, the APA is recommending that it is at 21. So that's probably where this, where they got some of that information from. Now, another thing to know is that people who are at 27.5 plus or minus 4% body fat, they had better weight maintenance for a year after discharge. Now, they also did have leptin changes, which are affected by the amount of fat we have. So they had a higher percentage of, or they had a higher leptin than the people who didn't do well with maintaining their weight. And so the percentage of body fat and leptin, they were significantly higher in the group who maintained weight, but there were no differences in pre-discharge BMI, duration of illness, and duration of amenorrhea. I have mentioned this to some patients because I think in culture or popular culture that there's this idea that the lower the body fat, the better. And so some of our patients will take that as, I just need to be as low as possible or as low as weight as possible or low body fat. But really, we're wanting people to have, about a quarter of their body weight to be body fat. And I think that really normalizes it for patients to where it's like, oh, that's not a bad thing. That's totally natural and normal and expected. Okay, so let's talk about atypical anorexia as well. What the goals are, according to this study, is to reverse eating disorder behaviors, resolve complications of malnutrition, so that'd be amenorrhea and bradycardia, and then limiting the risk of obesity. Now, we are very much health at every size informed, and one thing to know is that really that risk of obesity, if we do 4 things, I think it's 4 things, it would make the risk of dying it would make our risk of dying the same as if somebody's body weight were in more that normal place. And those would be, eating fruits and vegetables, exercising 12 times a month, not drinking alcohol. It actually says drinking a little alcohol or not. I'm sure both are fine. And the other one's not smoking. Those 4 things, which are relatively simple things, will limit that risk of obesity, because I think some people will think it's that it will affect their health, and being in a larger body doesn't make somebody unhealthy at all. So we need to be really aware of that and aware of our biases with atypical anorexia. So let's look at nutrition intervention and the dietitian's role. So in some eating disorder manuals, 91% of these eating disorder manuals had nutritionally focused content, but only 36% of the manuals recommended a dietitian be consulted as part of the team. Out of 22 eating disorder treatment manuals, 60% contained nutrition information not substantiated by evidence. I was reviewing a manual out of England, and I really liked a lot of the information there. There was some really good stuff, but when some different recommendations for nutrition were listed, there were some that I'm like, well, that's not really accurate. And I did look to see, well, where did you get that information? And there was no resource. So some of it might be their clinicians' opinions of food and how somebody should eat. So using a dietitian, we provide nutrition information that's substantiated by evidence and allows the therapist to focus on emotions, mental health, and reasons for developing an eating disorder. I oftentimes have dietitians, like I had one recently who said, 95%, since we always say 95% to 98% of diets fail, where did that come from? Where did that first come from? And so we'll go back through and look to make sure we have that original information so that what we're saying is actually accurate. All right. So when you only have a hammer, every problem looks like a nail. And I can tell you, this was my experience when I was younger. Intuitive eating for me was the way everyone should recover. I still think it's super fabulous because you don't have any beliefs about food being right or wrong. You eat when you're hungry, you stop when you're satisfied, and really everything's fine. So you don't ever have to look at what am I supposed to be eating on a piece of paper. You don't have to do that. So I still really like intuitive eating. I love teaching that to people, and I think that offers them a lot of freedom. But it might not be the way for everybody. So why have a variety of nutrition interventions? Well, it's dependent on what the patient or parents, what they want, what they're willing to do, and what they're able to do. So whatever a person wants for their recovery is okay. And I have at times in supervision with dietitians, mentioned, okay, maybe their recovery is going to be, you know, a certain way. And the dietitian's really resistant because I think they don't want that for that person's life. But remember, keep it open-minded. What they want is very important. Now, the goal should be full recovery if that's what the patient wants. Yes, go for it. Let's look all the way to the left of this screen. So some of this might seem a little bit shocking, and I'm going to explain why. This is, I think, this way. So the left says they're not willing or able to consume food. So what I would say is, hey, maybe a peg tube would be best there, because then they can go do life, and then they can just maintain that nutrition, and whether it's a parent helping them out with that, because it might need to be, then at least they're able to do their life as opposed to institutionalizing the person. Now, another way to think of this is if somebody had a medical issue that they could not eat food, we would not think twice about giving them a peg tube. So think of it that same way, that it is, even though, yes, physically their esophagus does work, they're not able to consume food. So a peg tube may be appropriate. If they're not willing or able to maintain weight, so they'll actually ingest food, but they're not like, maybe they just don't want to weigh a certain amount and they don't want to eat. So family-based treatment for adolescent or emerging adults is, as far as the APA is concerned, 26 or younger. So that might be the way to go in both bulimia and anorexia. And it also could be more the zone plan. So zone plan is something we've been doing for a long time at the Center for Change, and it's very similar to FBT. And it really just kind of takes the structure of a treatment center and puts it at home. So that might be what's necessary there. And then it also could be that meal support from friends and family. So especially when a person, say in their, a patient I have, say in their 60s, what I've done with them is say, okay, well, let's find your friends that you have, that you eat with, or that you could eat with, and see if you can enroll them to having meals regularly and hanging out with them, watching a show after meals. And so that's been really helpful to create that community. The next is wanting to maintain weight, possibly lower than their goal or what's expected, but they have difficulty consuming food due to eating disorder manipulation. So this would be, say if I taught a person to eat according to a plate method, where they have an entree and two sides. Somebody who is in this kind of situation would choose the lowest calorie foods, or they would take a sandwich and 2 pieces of bread they'd call their main, the lettuce is a side and the turkey's a side. So using calories or using exchanges would make that very difficult. So that might be helpful for them. Now, if they're able to follow directions of plating food without significant eating disorder manipulation, we have a variety of options. They could do the rules of threes, which I believe it is like 3 meals, 3 snacks. You have a third of your plate is 3 different things. You use fat, protein, carbohydrate. So it's kind of everything is in threes. You could do an entree and sides, where you have the entree and then you have a side. And you might say you have 1 entree and 2 sides. So sides would be, you know, like half of a cup. Sometimes we'll have dietitians who will teach it in a fist. And if you have a parent who's very literal, this is actually a cup, not half a cup. So we'd want to discuss with patients or parents who are literal thinkers that it would really just be half of a fist. And then I've had patients that this has been helpful for. So it would be, they might know everything about, okay, yeah, entree, 2 sides, I know how that is. But if they were to make a plate for somebody that they love, what would it look like? And so I'm wanting them to plate their food as if they're giving it to someone they love. Now, all of these to the left of your screen are extrinsic ways of eating. Those are plans, they're written, except for the peg tube, it's not written, but they're external. outside of the person's body. What intuitive eating is it's an internal way of eating. So there aren't plans, there aren't rules. So if somebody's interested in intuitive eating and letting go of extrinsic plans of how to eat, intuitive eating would be helpful. And then you just are going to give them interventions to help them know how they're doing that. So we're going to talk about those interventions. At the center, we have something called challenges and extras. And really, this is more if challenges might be candy bars, extras might be extra food. So we might have a goal where I might have somebody who's working on weight restoration, or I mean anybody, but I would really encourage somebody who has a difficult time feeding themselves to ask for food. So that might be where this comes in. It also could be where somebody maybe is afraid of chocolate or candy bars. So it would be a way for them to challenge themselves that way. Oops, backwards. Okay. And we also do meals and snacks with our dietitian nutritionists. And that can be done in a variety of different ways. It could be where they're just kind of getting used to being out in an environment. It could also be more where we're practicing intuitive eating. A therapeutic food day. Now, this, we put this into play at the center, you know, a long time ago. And what it was is because patients would say, I can never, if you give me cheesecake, I would never stop wanting it. I will always want cheesecake. And so what we started doing was, for breakfast snack, lunch snack, dinner snack, we do cheesecake. And there does come a point when somebody's nourished, they've had regular meals, and they have it kind of consistently to where they want something different, where they're able to recognize, hey, my body doesn't want this anymore. This does not taste good. So that's kind of what that is. It's not to get somebody sick of it, but it's to give them a different experience of a food that they thought was really important to them. And then with challenging situations, that can be eating in certain places that they might have a difficult time eating in. And that can be done on PATS, but it also can be done with their dietitian. Abundance eating is for people who have a difficult time stopping when they're full, or they feel like they have to clean the plate. So we'd have people overplate their food, and then they would practice stopping. And it's just a practice. It's a skill. Covert behavior rehearsal is imagining eating. It's just like if you were to teach somebody to play basketball and they were to think about shooting a basket over and over, their ability to shoot that basket can improve, but just by imagining. And so the covert behavior rehearsal is something that, and this is mostly, I had a patient who, she had SMA, so superior mesenteric artery syndrome, where she couldn't eat, and she would just imagine herself eating because she was tube fed for 6 weeks. And when I started working with her, she had no issue eating out, and I thought she was lying to me about her stresses there. But so I asked her, what have you been doing? And she mentioned this, where she would eat at a Mexican restaurant in her mind and replay it over and over until she could do it and not throw it away or not purge it or whatever it was. But if you have patients who will imagine those, you'd be surprised, and they will be surprised, how hard it is to get through an entire sequence of eating and not throwing it away, feeling okay in their minds. Now, I've also had a patient where she had some things happen in the middle of the night when she was a child. And so when she'd have nightmares, she would wake up, and she's a lot older now, but would wake up and go and binge and purge. So we talked about covert behavior rehearsal for her to just practice during the day and to increase her ability to eat and keep food down. But she started doing it when she would wake up. So she would eat in her mind and then go find go hang out with friends after. And she would do that instead of getting up and binging and purging. And then after a while, she stopped doing the eating in her mind in the middle of the night. She would just hang out with friends and kind of make herself feel better in her mind. So it could be a tool that's used in a variety of different ways. So keep that one in mind. Hunger fullness monitoring is very important. Scavenger hunt is where you can take a lot of different challenge foods, list them, and have patients go eat them and then get the signature. And so it just kind of makes it more fun. Solo with food is where we'd have a patient in a room alone with a bunch of food for at least an hour. And so then they can practice being alone with food. And this really came up when patients are like, the only reason I'm okay is because I'm in treatment. And if I was alone with food, I would binge. So this is to give them practice being around a lot of food. And so they'll start feeling more confidence. Guided intuitive eating is where you're sitting and watching somebody eat and being very transparent as a dietitian with saying, okay, well, I noticed that I feel a little bit full in my stomach, or I feel some food in my stomach, it's not really full, but, or I'm starting to notice food doesn't taste as good. So that's more where I would talk about the satiety of food. When you get a little bit bored of what you're eating, or you start remembering I need to go do my dishes, or you start noticing it's cold or sweeter, like more sweet, or it's more salty, but where you get a little critical of your food, that's the real subtle fullness. So that's kind of where you can teach somebody guided intuitive eating, is paying attention to sensations, tastes, and interests, and following your interest around the plate. Mirrored eating is more what I was talking about with, it could be if somebody's eating a salad, eating the way they're eating. I found it very helpful with one of my ARFID patients when she was having a difficult time swallowing, and even difficult time swallowing like just any liquid, to where I would sit with her, I would drink what she's drinking, I would let it pool around my tongue, and so I could offer her suggestions about, okay, yeah, I can see this is difficult if you let it sit in your mouth a while, and could we do this or could we do that? And then grocery store. So sometimes just getting people in different environments to help them out so that they can see, okay, I can do this, I can be in these different environments and get food. Convenience store as well. It's important to be able to get food at a convenience store because you never know where you're going to be in life. Now, recovery commitments. These are ones, so we do 10 of these before patients are practicing intuitive eating. And it's more of what I'd say a modified intuitive eating. They still are having their 3 meals, their 3 snacks, but they're able to practice leaving food. After a while, they'll be able to more progress into, I kind of call it careful intuitive eating, where they're really aware of what they're doing, hyper aware. And then we'll get into more of carefree intuitive eating, and it's really where you just know your body's going to take care of you. So the first is eating 3 meals and 2 to 3 snacks every day. If you don't do that, you can't do intuitive eating. The next one is I'm able to be honest about my food intake and keep a food journal as necessary. The third, I've attained a non-restricted body weight where my body functions, so like periods, stuff like that. I am eating enough fat, protein, and carbohydrates so I have regular and recognizable hunger and fullness cues. So we can't be restricting one type of macronutrient. Everything's got to be on the table. I've made a commitment to not use eating disorder behaviors, even when I'm upset, triggered, or uncomfortable. I've given up dieting and diet foods. I have made a commitment to not weigh myself, calorie count, or read labels. This doesn't mean patients aren't going to know their weight at some point. They might, but they're not weighing themselves. It's not an indicator of how they're doing in any sort of way. The next is I'm able to tolerate the unknown and non-exact surrounding calories, weight fluctuations, and body fluid shifts. I'm able to recognize and monitor my hunger and fullness cues, super important. And they need to have a desire to eat intuitively. And then we practice intuitive eating. The other 2 are I'm able to respond to my hunger and fullness cues and have given myself permission to eat what my body needs and craves. And then the last one here is I can cope with emotions that I feel and the stress in my life without eating, purging, or restricting in response to the feelings. All right, so thank you for attending. And I'm going to turn it back over to Tamara.
Thank you, Rebekah. We have lots of questions. We won't be able to get to all of them today, so I'll give you all. Rebekah has put her email on that last slide, so you can reach out to her directly if you have a burning question that we don't get to. Before we get to the questions, excuse me, however, just 2 reminders. Number 1, when I stop the webinar, an evaluation will automatically pop up on your screen. If you'd be so kind as to just take 30 seconds to fill out that evaluation, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. We'd love to hear from you. Excuse me. And then lastly, about an hour after the webinar ends, you'll receive a separate email from GoToWebinar. It will look similar to the email you got when you registered. This one will come, as I said, about an hour after we finish, and it will have the link to take the online test. You must take the online test in order to receive continuing education credit. Once you pass the test, then your certificate will automatically be downloaded to your computer. If you don't see it on your screen, check your downloads folder, excuse me, your downloads folder on your computer. All right, Rebekah, here we go. Let me get back to the top. Okay, this question comes from Christopher. What if the client is not willing to consume food via the PEG tube either? Would that fall in the non-negotiables?
A PEG tube would most often be something that would be put into play more at home. And it would be more of with the parents. There are certain places that if somebody's really just limiting their food and they're in a real difficult place weight-wise, where their rights can be taken away and they can be put in treatment. We don't do that at the center, but a PEG tube would be more of you'd have to have a parent who would be like, okay, this is what we're doing, and they'd have to have some, like even young adults, if they're financially dependent on their parents, that's how that kind of works. And you just got to think of it as a medical necessity. But other than that, it might be where you're put into a treatment center in another state. Yeah.
Thank you. Suzanne's question is, can you tell me where to find more information about the zone plan? And I thought maybe you could just talk for a quick minute, Rebekah, about what the zone plan kind of looks like.
Okay. The zone plan, I'm not actually sure who made it up. It was something that Nicole Hawkins, our CEO, had brought in back in the late 1990s. So I'm not really sure if it's something that, maybe we will put it more out though so that everybody can know. But it looks like a table, and there's a red zone, there's a yellow zone, so it's kind of rainbow table. And this green zone or blue zone over here could be intuitive eating. Like a patient is maintaining their weight, they're eating a variety of foods. That could be that blue zone. If their weight starts going down or their purging goes up or whatever, they might move more to that green zone. And so it could be where, say, the parents plate their food for them. It could be where they have supervision after meals. So that's there. And then if there's even more of a weight loss or more purging, they'd move to more of that yellow zone. And there is a place in there where if they were at a certain place that more treatment or being admitted to a higher level of care would be where they'd go. Like that red zone, you're probably being admitted somewhere. So that's kind of what that is.
Thank you. Sorry, I didn't mean to interrupt. Go ahead.
No, that's it.
Okay. Excuse me, Jeffrey's asking, could you talk a bit more about helping patients learn, oops, I just lost it, hang on. My computer's being a little bit crazy, so give me just a second. Here we go. Sorry about that, Jeffrey. Can you talk a little more about helping patients learn how to intuitively eat? And I thought maybe, Rebekah, you could tell folks what it would be a good resource, like the intuitive eating workbook, that kind of thing.
Yes, it could definitely be the intuitive eating workbook. Some of it also, though, is that first one where they have to give themselves permission to eat everything. All foods are on the table. That's really that first step. And then it's being able to monitor the hunger fullness and being really good at paying attention. And you might have to help them with somatic cues of what hunger is, what fullness is, what it is to them. And then after that, it is that not coping with emotions by restricting or using behaviors. But the first thing is always that permission to eat. And there's the adolescent intuitive eating workbook. There's an adult one. Intuitive eating was really set up not for eating disorders. It was just for the general public, but it can work really well if somebody is interested in that. But you might have to do some desensitization to certain foods, and then also they're going to have to work on allowing all foods into their experience. So it's definitely a process, but it's definitely doable.
Great, thank you. Thank you again, Rebekah, for presenting today, and thank you everyone for attending. We're out of time, so we'll let you all go. We know many of you have patients to get through to at the top of the hour. Again, if you have a burning question for Rebekah, feel free to email her directly. You can also email to cfcwebinar@gmail.com, which is on all of your emails that you get when you register. You're welcome to send me a note there and I can pass it on to Rebekah. In the meantime, everybody be well and stay healthy, and we look forward to seeing you at our next webinar. Bye-bye.